for the CDC.
That sounds like
Blair.
Blair.
Blair, we're starting.
Blair.
Fuck her out.
Shut the door.
Blair. Yeah, just shut it.
What do you say?
You want to start so we can get out of here?
Oh, Blair.
Kindergarten.
Yeah.
That was Blair.
So, before we get started, I want you to know, I know how you spent your weekend. I spent my weekend repainting the anatomy lab. So, I want you to go over there. I took the white boards off, you know, the marker board. What? White. My daughter gets on me for saying white instead of white.
What?
Every time.
I got you.
Like when you squeeze.
I die.
Somebody needs some sleep.
All of
And
us?
it ain't me. Anyway, I took the not black boards off the wall. So the wall is behind it, right? And I painted the inside, the urinary lab. As soon as they finish the HVAC, I'll want to do the other lab to get that straightened out.
What color is it?
It's the same color as the office beside, it's not white. Anyway, what I want you to do is I want you to go over there and you'll see where Amber put her name, my wife and I put our names, my daughter put her name, she drew a mermaid, grandchild put a name. So what I want you to do is, when you're in a law firm, go sign your name behind,
Oh.
when I put the new board up there, it will be there forever.
Oh. Yeah.
Everyone will know.
No, that's cool.
So 100 years from now, it'll be like that elementary school here in Oklahoma where they took the chalkboard off and there was stuff from the early 1900s. So put whatever
I'm gonna put nominee on there,
politically
okay? I'll
correct
be the only one in
statement
100
you
years.
want. But, yeah, so I'll probably put the whiteboard up sometime, say next Monday or Tuesday. So sometime this week, go by there and just sign your name, put, whatever you want to put. All right, hematopoiesis is the study of the formation of blood elements. All right, so this is a lecture is under the pathophysiology heading. So we're going to talk about how this is done. If you focus on the formation of red blood cells, it's called erythropoiesis. The study of all blood elements is hematopoiesis. That's the difference. So if we take a 10 cc or 100 cc, whatever volume of blood straight out of the arm, and spin it so that the heavier elements fall out, then this is telling you what the hematocrit is. If you look at the percentage of that amount, and this is an aliquot. You ever heard of the term aliquot? A-L-I-Q-U-O-T is a unit of liquid, an aliquot. So this, let's say this is 10 cc's. And you understand that 10 cc's, cubic centimeters, is the same thing as a milliliter. Right? Everybody knows that. That there are 5 milliliters in a teaspoon, 15 milliliters in a tablespoon, 30 milliliters in an ounce. Never forget that. When you tell that mother at 2 o'clock in the morning that you want to give that 2-month-old 1.5 teaspoons of Tylenol, you have to know how many milligrams are in a teaspoon and how many teaspoons. You get where I'm coming from. Okay. This is 10 milliliters, we'll say. You spin it down, and 45% of that will be red blood cells. 45% of it will be red blood cells. On top of the red blood cells, You have what's called the Buffy coat. Buffy, like as in the Vampire Slayer, Buffy coat. It is a thin layer of leukocytes. You really can't see it on a cylinder, very thin. On top of that will be a very thin layer of platelets. It's also invisible. And on top of that will be plasma. Plasma, this is something else you can never forget. Plasma contains, the difference between plasma and serum is that plasma contains the blood clotting elements. If we took this tube and just set it on the table for about 10 minutes, the blood would coagulate on its own. When it coagulates, it's using up the blood clotting elements in plasma, so serum does not contain the clotting elements. It's clotted, it's the fluid left over from the clot. Plasma contains all. That's how I remember it, PA. Plasma contains all of the blood components, the solubilized blood components. Got it? All right, so now if we just focus on this volume here, plasma, what is, well, here we go. There's the layout there. In a male, about 45% is going to be the hematocrit. That's the hematocrit. The hematocrit is the volume, the percentage of red cells. In women, it's a little bit less. If you're less than 10 years old, it's down at around 35%. If you're a newborn, it's up high. The hematocrit decreases in pregnancy due to the increase in the amount of plasma. It's a dilutional effect. The amount of plasma volume increases in the third trimester of pregnancy, so you might get a blood count, a hematocrit from an 8-month pregnant woman and find out that her hematocrit is 28, and you go, oh my gosh, when in fact that would be normal because of dilution. There's the Buffy coat and the platelet layer. This is what I was going to talk about. So if we take that amount of plasma, 90% of plasma is just plain water. The 10% that's left contains essentially three things. The majority of it, 7%, contains proteins. 2.1% contains hormones, amino acids, vitamins, non-protein elements. And 0.9% contains inorganic salts, namely sodium chloride. So when you order IV fluids and you want to replace the same amount of salt that you physiologically have in you, you would order 0.9% saline. A 0.9% saline solution. That's why. Okay? Blood smears. Well, let's look at the blood formed elements. There are different ways to do it. Most blood smears, when I get a blood count on you, they run it through a machine called a Coulter counter. Coulter is a brand name that is turned into a generic name, kind of like aspirin. Aspirin is actually a brand name. It's owned by Bayer, the name is, but it's used generically to describe all acetylsalicylic acid. The same way with Coulter counter. Not that you need to remember that, it's just one of those things. Anyway, you spit it through this machine and it tells you the percentages and the amounts of cells that you have in the sample. There's also a way to do it manually, to count the cells manually. And if there's ever a concern about what you're looking at or what you're seeing, you can always request a manual CBC. I'll say something about that later on. Now, if you're gonna do a manual CBC, if you just put blood on a slide and look at it under a microscope, it's perfectly clear, you can't see anything. You just see the outlines of little clear cells, you can't see anything. So you have to stain it. And the two stains you use are eosinophil, not eosinophil, eosin and methylene blue. These two stains, you do them sequentially. Certain parts of a cell attract basic dyes, like methylene blue, and they'll turn blue. Others will attract acidophilic dyes, like eosin, and they'll turn a light pink. Or they won't really attract one over the other, and they're kind of a neutral color. And so when you describe cells, or any tissue, you describe it in terms of basophilia, eosinophilia, or neutrophilia, okay? You obviously can already tell that 3 of the 5 cell types we're going to be talking about have a preponderance of one of these types of stains. Basophils, eosinophils, or neutrophils. Ta-da! All right. One thing, we're going to start with erythropoiesis. You have to understand that the bone marrow churns out red blood cells at an enormous rate, but it does so only under the direction of hormones that are generally secreted by the kidney. In response to low blood count, a high altitude, suddenly go to high altitude, you get a gunshot wound, or whatever, or you have COPD, if you smoke, anything that reduces your oxygen carrying capacity, you churn out erythropoietin. Now, it can either be through naturally made erythropoietin from the kidney, or it can be through, you take the base form here, the base protein, under the stimulation of erythrogenin, which is produced by the kidney, to produce more erythropoietin. If you don't have erythropoietin, you don't stimulate the production of red cells. 2 things you ought to be able to appreciate right off the bat. If you're in renal failure, one of your problems is going to be anemia, because renal failure means a dead kidney, means no erythropoietin. 2 is, if I'm treating you for cancer, like leukemia or something, and I want to suppress your marrow for white blood cell cancers, but I want you to make red blood cells, then I'm going to give you injections of erythropoietin. And that's what's done, to stimulate the production of red cells. Everybody follow me? Hemoglobin. Let's talk about hemoglobin for a minute. I just love this conversation here, because this is so slick. Hemoglobin is a tetramer. It's made up of 2 globin chains and 2 beta chains that are stuck together into one relatively enormous molecule. The alpha globin is produced on chromosome 16. And you actually have 4 copies of that gene, by the way. The beta globin is produced on chromosome 11. So here's the beta, there's chromosome 11. We'll say there's the gene for the beta globin, right? It says each chain is bound with a porphyrin containing iron. So, what's a porphyrin? If you take succinyl coenzyme A out of the Krebs cycle, remember the Krebs cycle? I'm not going to make you memorize that for the 50th time. If you take succinyl CoA, add a couple of glycine amino acids to it, that forms a pyrrole. That's a pyrrole right there. If you take 4 of these pyrroles and you stick them side by side, you see the 4 pyrroles right there? That forms a protoporphyrin. The If you take a protoporphyrin and stick a little hunk of iron in the middle of that protoporphyrin, like that, that forms heme. There's actually a series of diseases, genetic diseases, that involve this pathway. So people are not able to complete it, so they build up porphyrins or protoporphyrins in their blood, and these are called porphyrin diseases. They're a whole class, a whole family of them. They're anemias that are pretty significant. But anyway, this process produces heme. We're going to take one of these heme molecules and stick it in a globin. You got 4 globins to form one hemoglobin. If you'll notice right there, you see that little thing right there? That's the heme molecule in one beta chain. So a molecule of hemoglobin, you've got 2 beta chains and 2 alpha chains, right? 2 beta chains and 2 alpha chains. You got 4 irons. Each iron can carry 2 oxygen atoms. So one hemoglobin can transport 8 oxygen atoms, in case you're on Jeopardy. You don't need to know that one hemoglobin will carry 8 oxygen atoms. That is not necessary. I just think it's kind of neat. All right, any questions about that? All right, variations in hemoglobin are due to differences in the sequence of globin chains. They're not due to changes in heme, they're due to changes in the amino acid sequence of the globins. So if we look here, here are a few of the variations in hemoglobin. One of them I want to tell you about, I want to point out to you, is this one right here. Hemoglobin S is the substitution of valine for glutamate on position 6 of the beta globin chain. Here's the mutant, there's the wild type. Normally you have glutamate or glutamic acid there. And because of a change in the gene, instead of coding for glutamate or glutamic acid, it codes for valine. Going back to the genetic code, do you know how that works? Base pairing, you got the adenines and the thymines and the guanines and the cytosines and you know all that stuff. Your triplets produce code for an amino acid. A triplet base, 3 base sequences produce an mRNA. mRNA will code for an amino acid. In sickle cell disease, which is hemoglobin S, one of those amino acids is changed because of the chromosome. And it produces hemoglobin S instead of the normal beta globin. So if you count down 6 positions, 1, 2, 3, 4, 5, 6, that's supposed to be glutamic acid. Instead, it's valine. Valine and glutamic acid do not have the same charge. It changes the tertiary structure of this whole thing and makes it less able to carry oxygen. It also changes its structure, and because a red blood cell is nothing but a bag of hemoglobin, all of a sudden, instead of the normal biconcave disc, it's this jacked up sickle looking thing, because all of the hemoglobin is screwed up. It's actually not all of the hemoglobin, most of it. All right? You follow me? All right, so what do you have in you? Well, when you were born, when you were a little bitty baby, you had the predominant hemoglobin type was not 2 alphas and 2 betas. Oh no. It was 2 alphas and 2 gammas. Well, where's the gamma? Well, sitting right beside the beta globin gene is another one for delta. Right beside it is gamma on chromosome 11. So when you were born, this was turned off, that was turned on, so most of your hemoglobin is hemoglobin F. It has a higher oxygen carrying affinity than hemoglobin A. The 2 alphas and 2 betas. All right? When you turned about 6 months old, the genes one turned off, one turned on. The hemoglobin, the gamma gene started turning off, and the beta and the delta started turning on. So that around 6 months, your hemoglobin switched from predominantly hemoglobin F to hemoglobin A1, which is characterized by 2 alphas and 2 betas. Hemoglobin A2 is characterized by 2 alphas and 2 deltas. You have in your system normally about 97 to 2 to 1 distribution of hemoglobin A1, A2, and F in you right now. That's simple. Did I lose you?
Yes.
Yeah.
Okay, so when you were born, let me state it this way, because this is going to be an aha moment for you. You have a child, you have a baby with sickle cell disease. I'm a carrier, my wife's a carrier. Our baby is going to have a 1/4 chance of having sickle cell disease. It's simple Mendelian genetics. So let's say my baby has sickle cell disease. Understand that sickle cell disease will not become apparent until the baby is at least 6 months old. Why? Because sickle cell disease only involves the beta globin. When you're a newborn, you don't have a beta globin. You're producing hemoglobin F. It's not until at 6 months do you switch the genes, the beta globin start synthesizing. The more beta globin you produce, remember it's going to be sickle cell, the position 6 on the beta globin, the more you produce, the more severe the sickle cell disease. Does that help? Okay.
What's happening to the delta stuff then at 6 months?
It stays about the same. It stays about the same. You will learn this week that there are certain conditions, like, let's say sickle cell. Let's say you have sickle cell. What would be, if you could do anything in the world, you know, like putting the water molecule in the light rays to get it to Africa? If you could do anything in the world related to what you know right now, what would you do to cure sickle cell disease? Well, one thing could you do that would cure sickle cell disease?
Stop that substitution.
I'm not sure what you said, but if you said, what I would do is I would switch this gene back on and have them produce hemoglobin F. That would cure sickle cell disease. Would it not? Voila. Voila, and by the way, the word is, it starts with a V. It's not like Oklahomans who say voila. It's voila. That is a treatment for sickle cell disease. I'm gonna treat you with hydroxyurea, which is a drug that turns on hemoglobin F. Does that make sense? A little bit of sense? Yeah. Tonight, after you've had some rest, you get up in the morning, you'll say, oh, this is really kind of easy. It all just makes sense. Okay.
It's really not a W.
Pardon me? Okay. Marrow. There are two types of marrow. Well, like where you started developing cells. When you were a tiny little embryo, you remember that yolk sac thing that was up into the placenta? That's where red blood cells started to be born, or started to be developed. Because as you grew, you outgrew the diffusing carrying, the ability for oxygen to diffuse in you. You had to develop red blood cells. They started out in the yolk sac. They moved over to the liver, to the spleen, and then later on, the red blood cells started being produced in the marrow, sometime around 2 months or so. The clavicle was the first bone I say, because it's mostly cartilage at this point, to produce red blood cells. Now, as an adult, well, when you were a little child, most of your bones produced red blood cells. But as you got older, and I think I said this during anatomy, your long bones stopped producing marrow so much as they became a marrow reservoir because they filled up with fat. So if you look if you crack open a long bone, it's going to have a lot of yellow fat in it. That tells you the two types of marrow. There's red marrow and yellow marrow. Also, you can call it hematogenous marrow, the red marrow, meaning it's actively forming blood cells. And as an adult, that's really confined to the flat bones, like your sternum, your iliac crest, your skull, and your vertebral bodies. Those are about the only places right now that you make blood elements to any degree. But if you were to suddenly climb up Mount Everest, you need more blood. The yellow marrow can convert back to red marrow if it needs to. This is an example of the marrow. This is a piece of bone right here. This is a spicule of bone. And you see all these billions of cells that are within the marrow. This is red marrow over here. This is yellow marrow. That right there represents one adipocyte, or one fat cell. So 1, 2, 3, 4, 5, 6, 7. So you see that most of the marrow is filled with fat cells. There is some marrow, red marrow, but mostly it's fat. Okay? Erythropoiesis. These are the various stages of red cell maturation. You start out with, and it goes in this direction here, you start out with a stem cell. That cell, under the action of erythropoietin, starts to develop. The first recognizable form here is a proerythroblast. A proerythroblast, now what are you getting to? What you're getting to is a bag of hemoglobin. Hemoglobin is a huge protein. So these are going to be protein synthesizing cells. Lots of rough endoplasmic reticulum, lots of ribosomes, lots of mitochondria, lots of nuclear material to code for all this hemoglobin, right? So, hemoglobin synthesis can begin, the cell can divide. So you've got a stem cell that gives rise to, here's a stem cell, that is going to give rise to a proerythroblast here. It can divide. The next recognizable form is called a basophilic erythroblast. Remember I said early on, I think in anatomy, that blast means a more immature form. Basophilic erythroblast, the next recognizable form will be a polychromatic erythroblast. And then the next recognizable form is called a normoblast. Now, look over here on this side. Each of these steps takes about a day. 1, 2, 3, 4. And around on day 5 or so, the nucleus of a normoblast becomes what's called pycnotic. In other words, it condenses down so much, it's just a tight little ball of all this chromatin material. But you should appreciate that when a chromosome condenses down, it cannot code. In order for you to be able to transcribe a piece of DNA, it has to be uncoiled. This is so tightly bound down, it's useless. Therefore, it becomes eccentric and it's extruded. When it's extruded, now you have a cell here, you have a cell with no nucleus. This cell is called a reticulocyte. And the reason it's called a reticulocyte is because it has a little bit of, it has a few spots in it. It's reticulated, and those spots are retained mitochondria and ribosomal RNA that's basophilic. So you see these little spots in a red blood cell, or an eosinophilic red blood cell. It's a little stippling, okay? That's why it's called a reticulocyte. So, to get a reticulocyte takes you about a week. Now normally, you have about, if I were to draw your blood and just look at the red blood cells, about 1 to 4% of those would be reticulocytes, because you're making them constantly, right? 1 to 4% would be reticulocytes. It says 1% here, but it's 1 to 4%. That would be the normal retic count. If you have iron deficiency anemia, you have less red blood cells, right? And I diagnosed you with iron deficiency anemia. I've done the test. You have iron deficiency, you're a menstruating woman who eats poorly. Anemia, iron deficiency anemia, is very common in people your age. So what's the treatment? I give you iron. I give you iron pills. Okay? You start taking iron pills. How do I know that it works? Because the reticulocyte count will go up. When? It'll be a week. Don't even look before the end of the first week. So if I get you back in, Meredith, and your reticulocyte count is now 11, that's good. How about if it's still at 1?
I didn't take it.
What?
I didn't take it.
Well, that could be one reason they didn't take it.
It's not iron deficiency.
I don't have the right diagnosis. It wasn't iron deficiency, it was the fact that she has pica. She eats lead paint. Lead poisoning can cause what looks like an iron deficiency anemia. We just had this whole thing Friday afternoon about not jumping to conclusions about stuff, and now I just bit your ass, right? If you think hypothesis, right? Not diagnosis, hypothesis. You're a young menstruating woman, first with anemia. The first thing on my differential is iron deficiency. But you also have to put other things on there as well. And if I start treating you with iron, and it doesn't move the retic count, you better start thinking about number 2, 3, and 4 on that differential. What were we talking about? Okay. So here we go. If you'll read over here, you don't need to memorize the size of these cells, but what you should appreciate is the cytoplasmic to nuclear ratio changes. quite a bit. The cell becomes, it starts out quite blue, and then by the end becomes quite red or eosinophilic because of the hemoglobin itself. There's some other things you need to appreciate. The size eventually will get down to about 7 microns. It is biconcave to increase surface area. In addition to the hemoglobin, it has a stroma made of protein. That keeps the shape. It has a scaffolding inside of it. If you measure the size of the RBCs on a culture counter, and they're greater than 9 microns, they're considered macrocytic. If they're less than 6, they're called microcytic. So if I have iron deficiency anemia, there are 2 things you would expect. One is that you would not have enough hemoglobin, right? Because you got to have iron to make the heme. So you're going to have a decrease in the amount of hemoglobin. And if you have a decrease in the amount of hemoglobin, what do you think the size of the cell is going to be? It's going to be small. What do you think, if you look at a red blood cell, normally, it's nice and red after you stain it, right? It's nice and red. If it doesn't have enough hemoglobin, it's going to appear washed out. The characteristic of color is called chromia. So a hypochromic, microcytic RBC is characteristic of anemia, and of lead poisoning, and of chronic disease, and of thalassemia, and that's on and on with the differential. Hypochromic, microcytic. For those of you alcoholics out there who are deficient in B12 and folate, what that causes, it makes the cells swell. Big cells of alcoholism are characterized by a macrocytic anemia. And finally, these little humps of RNA and stuff that are retained in a reticulocyte, if they clump, they're called Hal-Jolly bodies. If they clump in the form of a ring, because you're dealing with a biconcave disc, and they're just going around the flattened middle, they're called Cabot rings. When you see on an explanation of a blood count that Cabot rings were present or Hal-Jolly bodies were present, that's always a pathological finding. You have to find out why. And you're going to hear those terms in your career, so you should just know that they're symptoms of chronic disease. Yes, Lisa.
Will macrocytes appear a different color?
Typically not.
Like they wouldn't be redder? or
Not
more
really.
red?
They're just bigger.
Okay.
Here's a summary of erythrocyte maturation. This is kind of what you need to have. All right, platelets. Thrombocytes are cell fragments without a nucleus. They're small. I think I showed them to you on slides before. They arise from a budding off of a huge cell in the marrow called megakaryocytes. Did I mention that before?
Yeah.
Okay. The membranes are rich in the glycosaminoglycans, glycoprotein 1B, 2B, 3A, that sort of thing. It makes them sticky. They have granules in them that contain serotonin. 5-HT is serotonin. Serotonin, when you dump serotonin on blood vessels, it causes them to contract. The blood vessel does. Thromboplastin, if you remember from the clotting lecture. Thrombostenin is also in there, and it helps to withdraw the clot up. you recall that. The lifespan of a platelet in circulation is only about a week. And you run through about 10% every day. And I think I mentioned to you before, if you take an aspirin, what happens to bleeding time? This is why. Okay. This is a megakaryocyte right here, sitting in there with all of the different blood elements. And you can see here the little platelets budding off of the outer membrane of the cell. Really cute. And these are the platelets in circulation, the little platelets among a field of RBCs. Now let's talk about white blood cells. White blood cells, there are 5 varieties I've told you about before. They're divided into 2 categories. Granulocytes that have granules in them, and agranulocytes that, well, they still have granules, they're just not as prominent. The first one we'll talk about will be neutrophils, and here's a whole bunch of names for neutrophils, as I've probably mentioned to you before. The granulocytes arise from one stem cell, or one stem cell can give rise to either of the 3 types of granulocytes. You start out with a myeloblast. It starts to produce protein. It enlarges. It actually becomes a promyelocyte. And from here, you can't tell if you're dealing with a neutrophil or a basophil. At this point, you can't tell. It's not until from here you start going down one of the 3 lines. One of the 3 cell development lines, do you end up with a basophil, an eosinophil, or a neutrophil? The left side of this slide is in the bone marrow. Never will you normally find these cells in the circulation. The right side of the line is in the circulation. Now, of course, you'll find these in the marrow as they're getting ready to get injected into the circulation. But something keeps these guys from the metamyelocyte on over to the left in the marrow. The only thing that's in the circulation that's not differentiated is this right here. They call it a neutrophilic stab cell. It's also called a band, B-A-N-D. Nobody uses the term stab. That may be a British thing. We call them over in the United States, these are bands. So a metamyelocyte is in the bone marrow. You can find bands in the circulation. Now, most of the neutrophils that you find in the circulation are going to be mature. But you'll have about, again, up to about 4% bands. If you wind up with an infection that the neutrophil is being called upon to fight, it will start turning out more bands, so your band count will increase in bacterial infections. If it doesn't, then you have to wonder about your ability to mount a defense. Any questions about these lines here? If you look at bone marrow, this is a sample of bone marrow, you see you've got all of these bizarre cell types in that bone marrow. One of the hardest things I ever did in graduate school in anatomy is taking histology and have to identify all these freaking cells in bone marrow slides. It was really, they all looked blue to me, so it was difficult. All right, let's talk about myeloblasts for a second. Let's go and review each of these. Myeloblasts, again, the first recognizable form from the stem cell. Promyelocyte gets bigger, it's got an indented nucleus. You start getting the appearance of granules that later on in the neutrophilic range, lineage, these cells are neutrophils. They're not taking up either the methylene blue or the eosin to any degree. They're just sort of a salmon pink color, I think. It's really hard for me I have to look at other characteristics because I'm red-green colorblind. Yellow, pink, and salmon pink to me look gray. So they all look gray. So I have to look at the cell versus the color. Anyway, here's a thing about the band stage right there. If you have an increase in the number of bands, it's called a left shift. And that's a term you should put into your lexicon that when you're describing something, we have, the patient has a neutrophil count of 18,000 with 10% bands. That is a left shift. That's telling your preceptor there's something bad bacterial going on. A mature neutrophil looks like this. You have these nuclear clumps that are connected by tiny little strands, 3 to 5 clumps is what you'll see. That's why they're called segmented neutrophils. If I were to take a blood smear from you and count 100 white blood cells, about 60% of them would be segs. Normally, about 60 to 70 or so would be segs. That's normally what you have circulating in your body. They only live in circulation about half a day. You turn over 150 gazillion of them every day. You produce a ton of them every day. Now what happens is, they're in circulation. What they're going to eventually do is try to crawl out of the circulation into the extravascular space. That's what it says. It only lives about half a week in the connective tissues. And it's looking for invading bacteria, for apoptosis of normal cells. Is looking for something to eat. For those of you who have 2 X chromosomes out there, one of them is inactivated and will be off the end of the nucleus. It appears to be like a drumstick. I'm not sure I have a picture of it. It appears like a little drumstick, like a chicken leg. That's the inactive X chromosome. Men, the only X you have is active, so you do not have a drumstick. From a blood smear, that's how you can tell if it's a woman or a man you're looking at. Demargination is something you should appreciate. When you have any type of stimulation of the sympathetic nervous system or sympathetic-like response, these neutrophils that are within the vascular space go outside the backwards. These neutrophils that are outside the vascular space crawl back in the vascular space like you wouldn't believe. So if I got a sampling of your blood and found your neutrophil count, let's say was 60%, and I gave you an albuterol breathing treatment because you're an asthmatic, because albuterol is a sympathomimetic. Remember, it dilates the airways. That mimics the sympathetic nervous system. 15 minutes later, I repeat their CBC, and now your segmented count is up to 85%. That's how fast that can occur. These cells just pour back into the circulation in response to an adrenergic challenge. That's called demarginalization. And you gotta be aware of it. If you have somebody on steroids, and you get a white count, and the white count is elevated, but most of it's due to an increase in the number of segs, you gotta realize this person does not have an infection. You caused that elevation. It's not related to infection, it's related to the drugs.
What did you say that's called again?
It's called demarginalization.
Oh, okay.
When segs, and it only happens with segs, pour back into the circulation. Here's a neutrophil here. I still don't see a drumstick on there. These guys, phagocytic activity is what these guys are really known for. They get in there and they will eat up all sorts of garbage. So if you have a bruise on your skin or something, all that exsanguinated blood, all the dead tissue, these guys are going to come in there and start cleaning it up. They come in fast, they go away fast. Eosinophils, you only have no more than 4% in circulation. So 60% segs, 4% eosinophils. The thing that characterizes them is that the nucleus has two lobes. And you see the granules are very eosinophilic. They're red. These guys are predominate in turn in, especially with parasitic infections. They have lots of peroxidases and neurotoxins that will kill protozoans, nematodes, all sorts of crap that you might be getting in your system. One thing they do is they will help tamp down the allergic response. They help reduce the amount of histamine. So for those of you with seasonal allergies and you've got all this histamine pouring out of mast cells and things, the eosinophils would try to slow it down. Remember we were talking about that little drop of clear snot on your nose being a sheet of eosinophils? That's what it's doing. It's trying to slow down the allergic response. Basophils, basophils are, they're the least common cell in the circulation. There's only 1% or less. They're hard to find, and they are they're blue. That's why they're called basophils. And there's so many granules in them. It's even hard to see the nucleus. Very hard. But those granules contain a ton of heparin and histamine. Here's a basophil right there. You see, that's a really dark cell with all the granules. You need to read these biographies over here on these cells. It kind of emphasizes what I've been saying. Right? Agranulocytes. There are, before we do the agranulocyte, let's take a break. You might want to, some of it look like this.